Welcome to the Deep Dive, the show engineered to cut through the information overload and really deliver the critical insights you need. Today, we're plunging into a topic that's both profoundly challenging and incredibly rewarding in our field: traumatic hand amputations. These aren't just physical injuries. I mean, they're life-altering events, right? They have significant psychological, socioeconomic consequences for our patients. Our deep dive today is on upper extremity replantation current concepts, and we're building on that really important work by Purchas and Friedrich. This field, it's really changed a lot since the 60s. The initial focus was pretty much just achieving replant survival, which was, a monumental feat back then. But today, our goals are, well, they're far more nuanced. We're looking at maximizing functional outcomes and surgical efficiency. As plastic surgery residents and attendings, you're the ones navigating this complex landscape. Surgeons are tackling incredibly intricate procedures, even replanting digital tips in children, while also balancing patient selection, cost containment, and, frankly, patient expectations often shaped by pop culture. So our mission for you in this deep dive is to pull out the most critical insights, the clinical applications, those practical pearls from this source material. We want to sharpen your surgical decision-making, elevate your patient management, and give you some invaluable knowledge for board prep. Today, we'll unpack this, starting with that shifting paradigm, then the go-no-go decisions, injury types, ischemia, patient factors, surgical techniques, and finally, the bigger picture. Okay, let's dive in.
It's truly fascinating, isn't it? How much the underlying philosophy has evolved. Like you said, those early days, maybe the 60s, 70s, were largely about proving replantation was even possible, saving the limb almost at any cost. But our current focus, it's much more refined. It's really about identifying preoperatively which patients, which injuries are most likely to get an excellent functional outcome, and pairing that with the most efficient surgical techniques we have. So yeah, it's not just about survival anymore.
Right.
Quality of life, the actual utility the patient regains, that's paramount.
That's such a critical distinction. And it leads us right into that crucial go-no-go decision. This is where it gets practical day to day.
Yeah.
It's rarely black and white, is it? We're weighing so many things: patient age, how the injury happened, how bad it is, their overall health, what function they might get back, and maybe most critically, their motivation. That rehab is tough.
Absolutely. Motivation is huge.
So, okay, let's talk about the green lights. When do we almost always go for replantation? What are those top indications?
Well, the thumb rule is number one. The thumb replantation is almost always attempted. Its function is just indispensable, right? 40, maybe 50% of hand function. Even if you only get limited motion back in a replanted thumb, it's almost always better than any prosthetic or other reconstruction.
Okay, thumb first. What else?
Multiple digits. Replanting several fingers is usually indicated because losing them is just so debilitating for hand function. In those complex cases, we're often strategizing, prioritizing the thumb and maybe the middle finger to preserve at least some pinch and grip. Sometimes that even means transpositional replantation.
Right, moving things around to maximize function. And what about amputations at the hand level itself, like mid-palm?
Mid-palm or hand amputations, generally, yes, they should be replanted. Any successful procedure there is going to give better function than a prosthetic. A little nuance for planning, though. Replantation tends to be more successful at the palmar arch level compared to the common digital arteries, usually because you get better intrinsic muscle recovery there.
That's a great clinical point. And for single-finger amputations, you mentioned a specific anatomical landmark.
Yes, the FDS insertion, the flexor digitorum superficialis. For single-finger amputations distal to the FDS insertion, replantation is often tried. The thinking is clear. You get better overall digit function because you preserve that PIP joint motion, the proximal interphalangeal joint. Even if the DIP joint, the distal one, gets stiff or even fuses, the data shows an average of about 82 degrees of active motion, which is way better than the 35 degrees you typically see with more proximal amputations.
Okay, that makes sense. And there's one group we always strongly consider.
Absolutely. Pediatric patients. Kids. This is a really strong indication for any amputation in a child. They just show superior functional recovery, and amazingly, the replanted parts often have the potential for normal growth. That's a game changer.
Huge difference. Okay, so those are the strong go signals. But just as important, especially for residents learning the ropes, are the situations where we need to pause, think twice, maybe even say no-go, the relative contraindications.
Definitely. You're looking for clear red flags, severe crush injuries, really mangled parts. The prognosis there is just poor. Multilevel amputations are another big one. Think about that picture. Figure 4 in this source. The radial arm saw injury hitting multiple levels. That's tough.
Right.
Obviously, if there are concomitant life-threatening injuries, those take priority. Patient survival first, always. And then patient-specific things like severe atherosclerosis, or if you strongly suspect they won't comply with the rehab, that rigorous rehab is absolutely essential.
And just like there's a strong indication for distal single-finger amputations, there's a relative contraindication for the more proximal ones.
Exactly. Specifically, amputations proximal to that FDS insertion. The expectation there is often pretty limited motion restoration, so the functional gain might not be worth the complex surgery and rehab. But there's a critical exception. Patients in really manually demanding jobs, think musicians, maybe craftspeople, for them, even limited motion might be incredibly valuable. So you might consider it.
That's a really important nuance. So for residents prepping for boards, what's the quick takeaway, the clinical pearl for indications and contraindications?
Table 1 from the source material is your friend. Know it cold. Always remember the thumb rule and the pediatric imperative. Always think thumb, always think kids. And be cautious with prolonged normothermic ischemia time that's warm time. We'll get more into ischemia nuances later, but that's a key contraindication to keep in mind.
Perfect segue. That brings us right to how the injury itself, the mechanism, the level, really dictates the outcome. Decoding that injury is critical.
Absolutely. It's probably one of the most important determinants of both survival rates and the ultimate functional outcome. I mean, the difference between a sharp, clean amputation versus a crush or an avulsion injury, it's stark. That meta-analysis by Dickin really lays it out. Sharp amputation, something like 91% survival. Compare that to crush around 68%, avulsion around 66%. Big difference.
Really big. And this is where things get really interesting, especially regarding avulsion injuries, like ring avulsions. Traditionally, those severe type 3 injuries, the complete degloving.
They were often seen as contraindications, right?
The classic teaching, yeah. Complete degloving of dorsal and palmar skin, blood supply, gone. Tough scenario. But advances in microsurgical technique, especially using vein grafts strategically, have really pushed the boundaries. They've expanded the indications and improved outcomes. There's a study mentioned 6 type 3 avulsions, all survived, and they got good motion back, protective sensation. Patients were satisfied.
Wow.
So this really raises an important question for us in practice, doesn't it? How do we take new data like this, data that challenges what we were taught, and actually integrate it into our clinical decisions?
It's a perfect example of how dynamic our field is. Things are always evolving.
Exactly. What was a no-go yesterday might be a maybe or even a go today with the right techniques.
Okay, let's move distally again. Those distal amputations where the FDS insertion is that key landmark. Right. So survival rates for distal phalangeal replantation are generally pretty good, around 86% overall. And there doesn't seem to be a major difference between Tamai zone 1 or zone 2 injuries.
Can you just quickly remind us what Tamai zones I and 2 are?
Sure. Tamai zone I is the most distal through the nail bed or distal to the DIP joint. Zone 2 is between the PIP and DIP joints, basically the middle phalanx. This classification helps guide our approach.
Got it. Thanks.
Even those very distal tip injuries past the nail plate insertion report around 85% survival. So technically, we can often save them.
But survival isn't everything? What about function?
Especially using that Ishikawa grading from Table 2, which residents definitely need to know.
Right, function is key. With Ishikawa subzones I to 3, those are all within the distal phalanx. Just getting progressively more proximal, you can expect mean DIP range of motion around 60 to 80% of the other side. Pretty decent. But for subzone 5 injuries, right near the DIP joint, where you often need bony fixation, you're typically looking at only about 30% DIP motion. And that leads to the debate, right? Replantation versus just revising the amputation stump, particularly for those subzone 4V injuries.
Exactly. That's a common clinical dilemma.
So what are the arguments for replantation in those tougher subzone 4V cases?
Well, the advantages are preserving the length of the digit, getting protective sensation back, keeping the nail, and potentially saving some joint motion, even if it's limited. There was that study by Hattery you mentioned. They found no difference in grip strengths between replants and revisions for distal tips. But the replanted group did show increased PIP range of motion. They tended to use the digit more often and reported less pain.
Okay, but the source also pointed out some limitations with that study, didn't it? Making it a bit tricky to apply directly.
That's right. The follow-up times were all over the place, and they didn't report outcomes separately for each specific digit or subzone. So it makes drawing really firm conclusions a bit difficult.
So the clinical pearl here. How do you advise residents or colleagues?
I'd say for subzone I to 3rd injuries, generally favor replantation. The outcomes tend to be good. For subzone 4, especially in the ring or small fingers, you really need to talk to the patient. Revision amputation might be a reasonable option if their main priority is a faster return to work. We're talking maybe 4 months recovery for replantation versus just 1 month for revision. But they have to accept a shorter finger and potentially a painful stump. It's a trade-off discussion.
That's excellent practical advice. Aligning expectations is so crucial. Okay, let's move proximally now. Mid-palm, wrist, proximal wrist amputations. What's the general recommendation there?
Pretty straightforward. Unless it's severely mangled or crushed, all palm and wrist-level hand amputations should probably be considered for replantation. Transmetacarpal injuries, for instance, have a high success rate, reported around 86%. Patients are generally very satisfied, and over half get nearly normal sensation back, which is actually better than some older studies suggested.
That's a strong endorsement for trying. Any clinical pearls for managing these specific patients post-op?
Yeah, a couple of things to keep in mind. Be prepared. About half of these patients will likely need secondary procedures down the line. Tendon releases, things like that. Also, expect cold intolerance. Pretty much everyone reports it initially. The good news is it tends to improve in about half the patients over time.
Okay. And for wrist and even more proximal wrist-level amputations?
The results reported are generally good. Patients often regain somewhere between 60 to 80% of the range of motion compared to their other wrist and fingers. They can usually pinch and grasp. A key limitation, though, especially if ischemia time was long, is intrinsic muscle function. That often remains limited.
And surgically, for these more proximal injuries, especially if there's been significant ischemia time, what are the key technical points?
If you're looking at prolonged ischemia, say over 6 hours warm time equivalent, for these more proximal amputations with muscle, you should really consider using a temporary vascular shunt. And critically important, reestablish arterial inflow before you do your rigid internal fixation. Let those built-up toxins wash out through the veins first.
Ah, okay. That makes sense. Get the bad stuff out before closing the system.
Exactly. And don't forget fasciotomies. Hand, forearm, maybe even the arm might need them to prevent compartment syndrome.
Right. Okay, now let's tackle that factor everyone talks about. Ischemia time. The clock is ticking. Or maybe it isn't, always. Especially for digits. There's a big difference between muscle and digits, isn't there?
Huge difference. Absolutely critical to understand. Muscle tissue is quite sensitive. It suffers irreversible injury after only, say, 2 to 4 hours of warm ischemia, maybe 6 to 8 hours of cold ischemia. But digits, because they lack significant muscle, are remarkably resilient. They can tolerate much longer periods up to maybe 6 to 12 hours warm, and 12 to 24 hours cold ischemia is often quoted.
And what's truly remarkable, though, are some of the extreme cases reported in the literature?
Oh yeah, they're astounding. There are reports of successful digit replantation after 33 hours of warm ischemia and an incredible 94 hours of cold preservation. Even hand replantation has reportedly been successful after 54 hours of cold ischemia.
Wow, that really highlights the resilience.
It does. These cases show just how tough digital tissue can be. So, connecting this to the bigger picture, the clinical pearl for residents and attendings is pretty clear. For digit amputations, cold ischemia time on its own should play very little role in the decision to replant or even to transfer a patient to a replantation center, unless, of course, the amputated part contains significant muscle, like a forearm amputation. Then the muscle ischemia time becomes the limiting factor.
That's a paradigm shift for how many of us were trained to think about time. And a quick surgical pearl for those more proximal amputations with prolonged ischemia.
In those cases, you might consider interosseous muscle stripping during the surgery. It could potentially help prevent later necrosis or fibrosis of those muscles.
Good tip. Okay, let's switch gears to patient factors, starting with age. We know kids are generally good candidates, but what about elderly patients?
Right, kids, as we said, almost always a strong indication. Better recovery, potential for normal growth, fantastic outcomes often. The elderly, well, historically there was definitely a bias against replantation in older patients, concerns about comorbidities, maybe slower nerve regeneration, reduced rehab potential. I remember cases early in my career where age was almost an automatic no. But the more recent data really challenges that assumption. Studies have not shown higher perioperative morbidity or mortality specifically related to age in replantation patients.
Really? So the risks aren't necessarily higher just because they're older?
Not in terms of major complications directly from the surgery itself. The main differences observed were things like higher rates of needing blood transfusions and maybe an increased need for support like rehab facilities after discharge, which makes sense. So the clinical pearl here is important. Age alone should not be a contraindication. You really need to focus on their functional demand. What do they need their hand for? What's their overall health status, their ASA score? And crucially, how likely are they to actually do the intensive rehabilitation? Those factors are far more important than just their chronological age.
That's a really empowering message, actually. Focus on the individual, not just the birth year. Okay, moving on to anticoagulation. This is critical for preventing thrombosis, especially venous thrombosis, right?
Sure.
That low flow state is tricky. What's the latest on aspirin versus intravenous heparin?
Yeah, thrombosis is the big fear early on. Aspirin is very widely used. Its use is mostly extrapolated from other conditions, like cardiology, and it's generally considered safe, especially when combined with standard DVT prophylaxis. However, it's important to note that clinical studies, specifically in microsurgery, haven't definitively proven that aspirin actually decreases thrombosis rates, though few show it increases complications either. So it's common practice, likely safe, but the evidence for efficacy in replants isn't rock solid.
Okay, so aspirin is common, maybe helpful, probably not harmful. What about 5e heparin?
Intravenous heparin. This is where the evidence is much clearer, and perhaps surprising to some. Studies show no benefit of routine IV heparin over aspirin alone for preventing microvascular thrombosis in digital replantation. And more importantly, routine IV heparin increases local complications significantly, about threefold. We're talking hematoma, venous congestion leading to ischemia or necrosis, infection. One study specifically noted that when they decreased their routine use of IV heparin, it did not negatively affect their overall replantation survival rates.
Wow, that's a really practice-changing finding. No benefit and increased harm. So the clinical pearl for residents is pretty stark then.
Absolutely. Routine use of intravenous heparin following digital replantation and revascularization is not indicated, period. Now, that doesn't mean it never has a role. It is warranted in very specific situations.
Such as?
Things like severely atherosclerotic vessels, or if you have unresectable intimal damage like you often see in bad crush or avulsion injuries, or if you encounter an actual thrombus intraoperatively that you manage, or if you've used thrombolysis successfully. In those specific high-risk scenarios, IV heparin might be considered.
Okay, reserve it for the really tough cases. And a surgical pearl related to heparin during the actual procedure.
Yes, heparinized irrigation saline with heparin in it should absolutely be used during the vessel anastomosis. That helps reduce platelet aggregation right at the repair site and prevent immediate arterial thrombus formation. So, local irrigation, yes. Systemic IV heparin routinely, no.
Got it. Local, good. Systemic, usually not. Okay, last patient factor. Smoking. We all know smoking impairs microcirculation, but what does the evidence actually say about its impact on replantation success? Is it as bad as we assume?
It's a bit murky, actually. There's some conflicting data here. While we absolutely know smoking impairs microcirculation, the direct effect on replantation survival rates specifically is unclear from the available studies. For example, one study looking at ring avulsion injuries found no effect of smoking history on survival. Another suggested preoperative smoking didn't impact outcomes, but postoperative smoking did, which intuitively makes sense.
Right.
But then you have an older study that showed a really dramatic difference, something like 61% survival for smokers versus almost 97% for non-smokers. So the data pulls in different directions.
So with these conflicting results, how do we handle this in practice? How do you counsel patients? Does it change the decision to operate?
It's definitely a key counseling point. Based on the current evidence, a patient's smoking history should probably have minimal influence on the actual decision to proceed with surgery, unless it's very clear the patient absolutely will not or cannot stop smoking postoperatively. However, you must warn them. Smokers need to understand they face a higher risk for complications and potentially for failure of the replant. You have to be direct about that increased risk.
Okay, counsel strongly, but don't necessarily use it as an absolute contraindication unless they refuse to quit post-op. Makes sense. Let's move into the art of the repair itself. Some interesting debates and innovations here. First, replantation without digital vein repair. That sounds like it challenges some core principles.
It absolutely does. The traditional teaching, the dogma, was always more veins are better. 2 venous anastomoses are superior to 1, and 1 is better than none. However, that dictum might not actually apply to the very distal injuries, specifically to myzome ball and 2. And the data here is contradictory. Some studies do suggest maybe a 10% survival increase if you repair veins in those distal zones.
Okay, so some data supports vein repair, but other studies.
Right. Other studies, especially those using the more detailed Ishikawa classification for distal injuries, found similar survival rates comparing artery-only anastomosis with alternative methods of venous drainage to cases where veins were repaired.
Alternative methods, what does that involve?
Several techniques have been described. Things like making a small stab incision near the nail fold, the perinacial region, to allow bleeding, or continuous topical dripping of heparinized saline onto the wound, even draining blood through the medullary cavity of the bone, or shaving off a bit of the nail bed or skin over the pulp, and using heparin-soaked pledgets to encourage outflow. Looking at the subzones, it seems venous repair might only be strictly necessary in subzone 4, the most proximal part of the distal phalanx. For subzones 2 and 3, replanted digits seem to survive pretty well with any of these alternative venous drainage methods, around 80–83% survival reported.
This is huge for practical surgery. The takeaway for residents: if you're dealing with a very distal injury, subzone 1 to 3, and you just can't find a suitable vein to repair, don't give up. The replant isn't necessarily doomed.
Exactly. The lack of a perfect vein does not preclude replantation for those distal injuries if you can use one of these alternative venous drainage techniques effectively. It broadens the possibilities.
Okay, next technique, vein grafts. When are they most useful?
Vein grafts are really valuable. They give you a reliable way to create a tension-free anastomosis. This is especially helpful when you can't or don't want to shorten the bone much, or when you're dealing with a larger zone of injury where the vessels are damaged over a distance. And importantly, studies consistently show that using vein grafts does not increase thrombosis rates or decrease replant survival. They work well.
So what does this mean for our surgical approach? When should we reach for a vein graft? It sounds like judging the vessel damage is key.
It is. And honestly, determining exactly when to use a vein graft can still be challenging intraoperatively. Assessing the true extent of vessel damage, figuring out how much you need to resect to get back to healthy, normal intima, that takes judgment. However, there is one key indication where vein grafts are very strongly recommended: avulsion injuries.
Ah, okay. Why specifically avulsions?
Because in avulsion injuries, the intimal damage, the damage to the inner lining of the vessel, can extend surprisingly far, sometimes up to 4 centimeters proximal and distal to the actual visible transection point. So you need to be aggressive with resection. Vein grafts allow you to completely excise all that damaged vessel segment and still bridge the gap for a tension-free repair. This leads to much better outcomes compared to trying a primary anastomosis on potentially damaged vessel ends in those avulsion cases.
That makes perfect sense. Get rid of all the damaged tissue. Okay, final technique point. Replantation without digital nerve repair. Again, this seems counterintuitive. Don't we always repair nerves?
That's certainly been the standard practice, yes. Nerve repair usually goes hand in hand with vascular repair. But there's a growing body of evidence suggesting that for injuries distal to the DIP joint, repairing the digital nerves may not actually lead to better functional outcomes in terms of sensation.
Really? What does the data show?
It's quite compelling. That meta-analysis by Chung's group looking at Tamai zone iron and 2 injuries, they found that 50% of patients achieved an average 2-point discrimination of 7 millimeters without any nerve repair. And another study by Hattery found that 96% of patients got protective sensation back, again, without nerve repair in those distal injuries.
That's fascinating. It really challenges a fundamental step we usually take. So the surgical pearl here for our listeners.
For those very distal injuries, the ones distal to the DIP joint, nerve repair may not be necessary. You might be able to streamline the procedure, shorten the operative time, without actually compromising the patient's ultimate sensory outcome.
Okay. Lots of evolution in surgical technique. Now, as we start to wrap up, let's zoom out a bit. Look at the broader implications, regionalization of care, patient management on a systems level. The reality is, fewer individual surgeons and hospitals are doing replants these days, right?
Unfortunately, that's true. It's a combination of factors. The procedures are technically very demanding. They take a huge amount of time and resources, and frankly, reimbursement hasn't always kept pace. There was a study of ASSH members, American Society for Surgery of the Hand. Only about 56% performed replantations at all. And of those who did, 62% did fewer than 5 per year. That's not enough to maintain high proficiency or confidence.
So where are most replants happening now?
The trend is clear: consolidation. Most procedures are now done at major academic centers or designated level I trauma centers that have dedicated teams and resources. And this trend supports the arguments for regionalization. Concentrating expertise should, in theory, lead to better outcomes and maybe even lower overall costs through efficiency.
Makes sense in theory. But regionalization has its own challenges, doesn't it? Particularly around patient transfers. What are the practical issues and patient management lessons there?
Oh, absolutely. This is a critical point. Decisions to transfer a patient for replantation need to be made very carefully. Inappropriate transfers are actually quite common. Many patients get transferred, often by air, only to find out they aren't actually candidates, or they choose not to proceed once they understand all the implications.
Why wouldn't they proceed after being transferred?
Various reasons. Sometimes they prioritize a faster return to work over saving the part. Sometimes its economic replantation is significantly more expensive than revision amputation. We're talking average charges around $42,000 versus $27,000 for alternatives in one study. Or sometimes, after careful evaluation at the replant center, they're simply deemed a poor candidate due to injury severity or comorbidities. And air transport, especially, adds huge costs, often unnecessarily if the transfer wasn't appropriate in the first place.
That really highlights a crucial patient management pearl for the transferring physicians out there. What should they be doing?
Before hitting send, transferring physicians must have a thorough discussion with the patient. Review all the options: replant, revision, the pros and cons, the recovery times, the costs. Help them make a truly informed decision before initiating the transfer. And if the decision, after that discussion, is not to replant, it's vital to document why. Discuss it thoroughly with the patient, record all the injury details, how the part was preserved, take photos of the hand and the severed part, maybe even send the amputated part to pathology for proper cataloging. Document everything.
And could technology help here?
Definitely. Telemedicine has huge potential. Being able to quickly consult with a replant center via video, share images, that can really help facilitate appropriate triage and avoid many of those costly and ultimately futile transfers.
That's a great point about leveraging technology. Wow, what a comprehensive journey through upper extremity replantation today. This deep dive has really underscored those dramatic shifts, hasn't it? Moving beyond just saving the part to this holistic focus on function, careful patient selection, and using efficient evidence-based techniques. For you, our plastic surgery residents and attendings listening, I think this really emphasizes how dynamic our specialty is. We constantly need to be learning, reevaluating beliefs, even long-held ones, based on new evidence. And in a field where our technical skills keep advancing, maybe this leaves us with a final provocative thought. How do we, as surgeons, continuously refine our judgment? How do we align the art of the possible, what we can technically do, with the art of the optimal for each unique patient? Especially when we're balancing the clinical evidence against that patient's deeply personal values, their life circumstances, their goals. And looking ahead, what role might emerging tech play? Things like advanced prosthetics, maybe even regenerative medicine. How might those influence these incredibly complex replantation decisions in the next decade? Something to think about. Thank you for joining us on the deep dive. We hope this has armed you with valuable insights for your practice and your preparation.